Okay, welcome everyone. Today in this series of Urology FRCS Viva preparation, we are discussing the penile cancer scenarios. Before heading towards the scenario, can I ask any of you have any questions? If you have doubts on any table, you can ask and then we'll go for penile cancer. What table you guys are reading? Any specific questions or queries?
Mr. Ananda, I want to ask treatment of acute urinary retention if no creatinine normal and just patient has acute urinary retention, no high pressure acute urinary retention.
Okay.
In UK, how you manage it?
Okay, so if a patient presents with acute retention and also has increased renal parameters, it means it could be a high pressure chronic retention. We should further substantiate it by doing an ultrasound, which may show hydronephrosis, and then placing a catheter, monitoring the urine output, IV fluid replacement, treating the diuresis, treating the electrolytes. It's a usual protocol. So your question is, there is no altered renal parameters, patients just presenting with urinary retention. We need to differentiate whether the patient has got precipitated retention or non-precipitated retention. By definition, precipitated means there will be some specific cause, like for example, binge drinking, a bout of alcohol in party, or constipation, something, or maybe some personal problem, something like that. That is something which is precipitated. And the other group is non-precipitated. They feel like no problems, and suddenly they had this urine retention. Sometimes they may have some voiding LUTS for a few weeks or few months before, and sometimes they may be already on tamsulosin and finasteride for many years, and now finally the medicine has failed and ended up in acute urinary retention. You need to differentiate the chronic urinary retention parallelly. Chronic retention means patient presenting without any pain, but the bladder scan or examination shows retention. So that is entirely different one. So for acute urinary retention without any signs of high pressure, if the patients were not on previously alpha blocker, we should start on alpha blocker. Alpha blockers, afterwards, we can give them a trial void. There is a study on Alfur study, which is done on alfuzosin, which showed that we can give trial void without catheter, which is abbreviated as TVOC, in 48 hours. So same thing can be applied for tamsulosin also. So you can remove the catheter after 48 hours. If the patient's prostate is palpably more than 30 cc, there is a role for combination treatment. You can start finasteride also along with the tamsulosin. For patients who are already on tamsulosin or finasteride combination and had acute retention, the best option is to go ahead with the surgical treatment. These patients, since there is no signs of any deranged renal parameters or upper tract damage, they can go with a flip flow valve. There is no need for a continuous draining bladder catheter. And patients with precipitated retention, like for example, binge drinking, constipation, they usually have a better outcome with trial void with catheter because there is a reason. And if you treat the reason, start them on alpha blocker, and then give a TVOC, the success rate is slightly on the higher side. Okay. Any other questions? Good. Any other questions? Can we go for the scenario?
Okay.
Good. So Fahad, let us assume that you are starting the scenario. You have a 72-year-old gentleman presenting with a lump in the tip of the penis referred by your GP under 2-week cancer pathway. How will you proceed? What will you do in the clinic?
I'll see this patient in 2-pathway clinic in the presence of cancer specialist nurse. I'll ask an history, physical examination, further investigation. In the history, I'll see onset and duration, this any associated symptoms, lots UTIs, any risk factor, such as the presence of foreskin, phimosis, a patient smoker, any previous bova, HPV infection. Then I'll ask about red flag, such as bleeding, or neurological symptoms, smoking. I'll ask about baseline sexual and bowel function, previous surgical, urological, medical history, and I'll do examination, including general examination, then examine abdomen for palpable bladder, then examine the external genitalia, looking if there is retractable prepuce. I'll examine the mass, size, how it should look. Is it related to the meatus? If not retractable, then I'll palpate it and see what is the size it. Then I'll do digital rectal examination, focus neurological examination, and I'll examine groin for palpable mass. Then I'll proceed for benile MRI with injected intracavernosal alprostaglandin. Then 10 milligram MCG. Then I'll do according to that, I'll counsel the patient for further investigation and treatment.
Okay, I mean, regarding the sexual history, I was asking you anything specific you want to ask in sexual history?
I'll ask if there is a sexually transmitted disease, baseline if there is erectile dysfunction or this what I want to discuss.
Any specific disease you have in your mind?
Yes, HPV 16/18, human papilloma virus.
Okay. Any history of exposure to any chemicals or any other exposure?
Yes, for ultraviolet, sporulin or phototherapy.
Okay, that's good. So what is the type of commonest penile cancer histology? What is the type of tumor?
Most common is squamous cell carcinoma, the usual type. Then there is a subtype such as papillary, bacilloid, sarcomatoid. This bacilloid and sarcomatoid high risk. Then with poor prognosis, and there is rarer benign cancer such basal cell carcinoma or melanoma.
Okay. Do you know any good prognosis histology types?
This such varicose or papillary.
Okay. Varicose, papillary, and Warty carcinoma are having good prognosis. The metastasis is very rare, especially for varicose carcinoma. There is no chance for metastasis. Okay. Very rare tumors which are non-squamous or adenosquamous or mucoepidermoid cancers. Okay. We have discussed the risk factors. Any other risk factors for penile cancer in specific, like phimosis or smoking? Do you know any other risk factors? How risk is the phimosis?
Phimosis is one of the most important risk factor. Then there is bad hygiene and poor smoker and multiple sexual partner. Like.
Okay, that's good. And you told me about the HPV virus. The most important types are type 16 and type 18. Okay.
Yeah.
So you are examining this patient. The patient seems to have like a red patch lesion in the glans. his perfuse is normal. What may be the diagnosis? What will you do next?
I'm concerned that it may be carcinoma on situ. Then I'll do a biopsy to clarify the diagnosis.
What is the other name for carcinoma in situ for penile cancers?
This erythroplasia decorate.
Okay. Any other pre-malignant lesions you are aware of?
There is a Boyne disease, this in the penile shaft. Then there is this what I remember.
You can say like bovinoid papulosis of the penis, which is HPV related, Page's disease and Bowen's disease or pre-malignant lesions. And lichen sclerosis is sporadically associated with squamous cell cancer. Okay, how will you classify penile intraepithelial neoplasia?
Classify all tumor cancer or
No, just penile intraepithelial neoplasia. How will you classify them?
I don't understand the question.
Okay, no, the penile intraepithelial neoplasia, which is the type of carcinoma in situ, what you are trying to explain, that is divided or classified as non-HPV related PIN or HPV related PIN or VART, penile epithelial neoplasia, VART basiloid, and there are some very rare types. So commonly penile intraepithelial neoplasia can be differentiated into non-HPV, HPV, VART or VART basiloid.
Yeah.
Okay.
Yeah.
How will you treat penile intraepithelial neoplasia?
I first try by conservative treatment 5-fluorouracil 5 days, then skip weekend once daily, and 4 to 6 weeks, or imiquimab 3 weekly for 6 weeks.
Okay, don't tell 5-fluorouracil and imiquimab or conservative management. They are actually treatment options. Okay.
Yeah.
What other treatment options available for intraepithelial neoplasia?
There is laser, carbon dioxide laser, and surgical, such resurfacing glands resurfacing.
Okay, when you're discussing the laser, discuss both carbon dioxide laser and Nd:YAG laser. Nd:YAG stands for neodymium yttrium aluminum garnet laser. The only issue with lasers is whenever you use laser, you should do rebiopsy after treatment to make sure that the lesion is completely resolved or responded. The best treatment or the total treatment is glans resurfacing, where the whole glandular epithelium is completely removed and it is replaced by split skin or buccal mucosal grafting. Okay.
Okay.
Good. What advice you will give when you are planning to treat your patient with topical chemotherapy?
Patient maybe have severe irritation and erythema, so I'll advise him if there is severe irritation to add corticosteroid, and to avoid intercourse during this. Or if we want to do intercourse, she must have a condom.
Okay. And you can discuss about the circumcision, because sometimes with perfuse in place, this treatment may be quite challenging. Sometimes presence of the healthy perfuse will help as the dressing also. So we can say that circumcision is advisable so that we can properly examine and properly apply the topical chemotherapy. And there is a good possibility the patient may progress to invasive disease, so patient should aware of this. And as you said, you should know few things like what is the response rate for circumcision with 5-fluorouracil, like 57% in intraepithelial neoplasia patients. And if the topical treatment fails, we can't repeat it. We should go for a definitive treatment like glands resurfacing. In UK, usually we'll ask them to apply once a day, every alternate days for 4 weeks, and then we will re-examine them. After applying, the hands should be washed clearly because they are all chemotherapy agents. As you said, condoms can be used for intercourse. And if there is, the patient should know that it can become quite red and inflamed. Patient can use some moisturizing agents like petroleum jelly if there is any dryness. As you said, hydrocortisone 0.5% cream is quite good. Usual review in 6 weeks time. If the lesion is completely cleared, patient will be taught on self-examination so that patient will re-examine and present if needed in laser. If there is a failure, we need to go for the definitive treatment. Okay. If you have to take a biopsy of a penile lesion, leave this intraepithelial neoplasia. Let us take, there is another patient who is coming with a proper like a cauliflower-like lesion in the glans penis. How will you take the biopsy?
There is incisional biopsy or excisional biopsy, or some take it by a true cut biopsy.
Okay, usually we don't do much true cut because true cut means it's something like a.
Hello? Hello?
Incisional biopsy or punch biopsy, as you said. Okay. When you are doing the biopsy, what are all the things you will look in your biopsy pathology report?
I'll ask about type of type and stage, how invasive, and if there is lymphovascular invasion, perineural invasion, and this.
No, can you hear me? Yeah, go ahead.
Yeah. I'll ask type of type and type and invasion, how stage, then perineural invasion, lymphovascular invasion, and the grade of the tumor.
Okay, the first thing is the anatomical site of the tumor, and then what is the histology type. We already discussed various histology type. You know the good histology and bad histology type. What is the grade of the tumor, and is there any perineural or depth of invasion, as you said, vascular invasion, as you said, and is there any urethral invasion, and is there any invasion into corpora spongiosum or cavernosum. With this penile cancer tissue, you can also get the P16 or HPV status. So patients who are HPV status positive, you need to be, you know that they have a little bit poor prognosis. In case if you are doing a definitive excision, like complete excision, then the pathologist should be able to tell you the surgical margin, whether the margins are free or not. Okay.
Okay. Thank you.
Hello.
Yes, yes.
Sorry, I think today the line is very interrupted. What is the T staging for heart for penile cancer?
TNM stage.
Yeah.
TX tumor cannot assist. T0 no tumor. TIS carcinoma in situ. T1 TA non-invasive. non-invasive squamous cell carcinoma, T1, T1A tumor invasive subepithelial connective tissue, but without perineural or lymphovascular invasion, or not poorly differentiated or undifferentiated tumor. T1B tumor invasive subepithelial tissue with perineural lymphovascular invasion. T2 invasion to corpus spongiosum with or without urethra. T3 invasion corpus cavernosum with or without invasion urethra. T4 adjacent invasion adjacent structure. In X, no regional lymph can be assessed. In 0, no metastasis. In 1, metastasis to 1 or 2 unilateral lymph nodes without extranodal extension. In 2, there is 3 or more unilateral lymph nodes and or bilateral positive lymph node without extranodal extension. In 3, this is extranodal extension or pelvic lymph nodes. M0, no MX not can't assist. M0 distant no distant metastasis. M1 distant metastasis.
The only thing is, in case of the T1, it's not perineural invasion. Even the perineural invasion you can say, but it's predominantly only lymphovascular invasion. Okay. Otherwise, your staging, everything is clear. M1 distant metastasis is clear. You can say for grading, it is up to grade 1, 2, 3, 4. Okay. So don't forget that, because a lot of time it is grade 1, 2, 3 in most of the tumors, but in penile cancer, it is grade 1, 2, 3, 4. Okay. You told me about MRI penis, artificial induced erection, and ultrasound for the groin. And any other investigations you are aware of?
There is penile ultrasound with an injection prostaglandin A1, but this operator dependent and but good specificity and sensitivity.
Yeah, that's good. What will you do when the patient requires partial penectomy? What guidance you will take?
I'll discuss him. I'll discuss case in MDT, and I'll discuss the patient that he need partial nephrectomy. Measure the size of the penis, if it good or not. The invasion of the penis or urethra. Then the patient, if he happy with complication and risk and alternative, then I'll proceed for partial nephrectomy, penectomy.
Yeah, I mean, the main thing for partial penectomy is you can excise the tumor with a good margin. Previously, we used to say a margin of like 1 centimeter or 2 centimeter. Now the studies have proven even a margin of 3 to 8 millimeter is enough based on the grading. If the grade of the tumor is 1, 2, 3, you can have the margins like 3, 5 or 8 millimeters. So approximately 1 centimeter is more than enough margin. So surgical margins have improved. The same principle applied even for renal cancers. So you need to remember that. Coming back to the residual length, you need to see what is the patient's expectation. If patient is expecting a good penetrative sex, we need to see whether the residual stump is good enough for penetrative sex. If the patient is very elderly, say maybe 60 years, 70 years, he's not interested in penetrative sex, he's more happy in passing urine, then you need to make sure that patient's penile stump is at least 2 to 4 centimeters so that he can maintain a good urinary stream by holding it. If the stump is very short, then unnecessarily the urine will dribble into the anterior wall of the scrotum, creating urinary related skin ulcers, etc. In patients who you can't maintain or create a good adequate stem for voiding, you need to even think about like a radical penectomy and then perineal urethrostomy. So the length of the penile shaft which you can preserve is important. You need to think about the cosmetic needs for the patient, penetrative sex expectations for the patient, ability to hold the penis and produce a good urine stream. Those are all the things you need to consider. Let's go to lymph nodes. So this patient, you do a partial penectomy and the report comes as squamous cell cancer grade 3. Okay, this patient has no palpable lymph nodes. What will you do? How will you manage a non-palpable lymph nodes?
I request groin ultrasound with fine needle aspiration. If the positive, any sides positive, I'll do a radical lymph node dissection. If not positive, I'll do DSMB, dynamic sentinel lymph node dissection, dynamic sentinel lymph nodes. Then according result, I'll treated the patient. If negative, just follow him. If positive, then I'll do a radical lymph node dissection. If or a modified lymph node dissection.
Okay, so if the patient has no palpable lymph nodes, so don't go more than that particular scenario. Okay, we are discussing only non-palpable lymph nodes. If the patient has no palpable lymph nodes, obviously you can't do fine needle aspiration, but as you said, you can use ultrasound. If the ultrasound shows a lymph node, you can do fine needle aspiration. If the fine needle aspiration is positive on, say, left side superficial lymph node, then the question comes whether you will go for a pelvic lymph node dissection or not. It depends upon the grade of the lymph node and also the grade of the primary tumor. If the primary tumor is, as I said, grade 3 with lymphovascular invasion, perineural invasion, and high risk features, then you may have to go for a pelvic lymph node. Regarding the lymph nodes, from the penile cancer, the lymph node invasion can happen into left or right superficial inguinal lymph nodes. But once a superficial inguinal lymph node is affected on one side, then it will go only to the respective side pelvis. It won't cross into the opposite pelvis. So that lymph node spread you need to be aware of. Okay.
Yeah.
Tell me about the sentinel lymph node. What do you mean by sentinel lymph node?
This is the first. The benign cancer is stepwise invasion lymph nodes. So we will get the first node after injection and get it for histopathology. If there is invasion, then if it's clear, no need further management. If there is invasion, then we will go skip to another management.
Okay. And how will you do the modified lymph node dissection? What are all your margins?
margin. It's in the upper inguinal ligament, in the medial adductor longus, in the lateral serratus.
Okay, I mean, I think depending upon the book you read, it may slightly change. The easiest answer is the superior most margin is the external oblique aponeurosis above the spermatic cord. The medial margin is adductor longus. The lateral margin is lateral border of femoral artery. So indirectly, you need to dissect the tissues around the femoral artery. The inferior margin is fascia lata distal to fossa ovalis. Fossa ovalis is the one where the vessels will penetrate the deep fascia and get inside. And you can exclude the regions lateral to femoral artery. If this modified inguinal lymph node, if this is clear, the need for further deep inguinal lymph node or pelvic inguinal lymph node is not there. You don't have to dissect the greater saphenous vein. Okay, so those are all the advantage of medial modified inguinal lymph node dissection. So in radical inguinal lymph node dissection, saphenous vein will be sacrificed. There is more complications. Explain me about your dynamic sentinel lymph node biopsy.
In the same days of surgery, I'll inject nanocolloid proximal to the tumor, or at 0, 3, 9, 12. Then this in radiology department. Then I detected the sentinel lymph nodes and mark it. Then when the patient shifted to OT, before induction, I'll inject methylene blue. Then I'll open over the mark and get the lymph nodes and sent for histopathology, frozen section.
Okay, that's good. So injection is correct. You can do it by two techniques. One is technetium 99 nanocolloid. So once you inject that, you should do it 3 to 4 hours before the surgery. So the nanocolloid will go through the lymphatics and reach the sentinel lymph node. And during the surgery, you will be using a patent blue dye 1 ml, which will be injected intradermal. Okay, you can't inject too deep, you can't inject subcutaneous, it should be intradermal. Intraoperatively, you will use a gamma probe, which is a Gegenmuller counter, which will help you to locate the hot node, which is due to technetium, or the node may be blue node. Sometimes you will get a separate hot node and blue node. Any node which is hot, blue, or both, they are all harvested. They are all sentinel lymph node. The meta-analysis have proven that there are plenty of studies, like 18 studies showed good sensitivity of 88%, which can be improved further with 2 agents. If you only use 1 agent like nanocolloid, it is 88%. If you use blue dye also, it increases a little bit more. There are some complications like skin infection, genital lymphedema, etc. Even with modified dynamic sentinel lymph node biopsy, but they're all relatively less. Okay. How will you manage a patient who is presenting with palpable lymph nodes? We have discussed non-palpable lymph nodes, where you can do dynamic sentinel lymph node biopsy or modified inguinal lymph node biopsy, or you can do an ultrasound guided FNAC as a starting procedure. If the patient presents with the palpable lymph nodes, how will you proceed?
I'll do ultrasound and fine needle aspiration, sent to histopathology. If positive, then for a radical lymph node dissection. If negative, either repeated it after 3 months, or go for dynamic sentinel lymph nodes.
Okay. Don't discuss dynamic sentinel lymph node biopsy in a patient with palpable lymph nodes. If there is a palpable lymph node, FNAC, or you can even do a modified inguinal lymph node because the node is definitely palpable. There is no role for waiting by giving antibiotics or anti-inflammatory, thinking that it may be due to an underlying infection or inflammation. Those things are out of practice. Previously, even it was mentioned in Campbell book, say 15 years back, but those are all now out of practice. So any palpable lymph node in a patient with a penile lesion, we should consider it as a metastatic lymph node unless otherwise it is proven. How will you do radical inguinal lymphadenectomy?
There is even open or will video endoscopic inguinal lymph node by يعني like laparoscopic or robotic. It's remove all lymph nodes and cyclotonize femoral artery and vein, and even sacrificed by saphenous vein.
Yeah, so it is quite a radical procedure. Previously, we used to transposition the sartorius muscles. Nowadays, we don't have to transposition the sartorius muscles because we have good techniques for that. The complications are like wound infection, skin necrosis, lymphedema, and lymphocyte formation. And how will you treat the pelvic lymph node dissection? What is your criteria?
It's lymph node, pelvis lymph nodes like prostate cancer. It's medially bladder, laterally obturator nerve, and external iliac, then inferiorly cloquet node.
Okay, and you can do a midline incision. With that, you can do even bilateral pelvic lymph node dissection if indicated. If patient has only positive lymph node on one side, only unilateral pelvic lymph node dissection is enough. Patients will benefit from adjuvant chemotherapy whenever the patients are having N1 disease. Even from N1 onwards, there is a role for adjuvant chemotherapy. What is your choice of chemotherapy?
This TBF, paclitaxel, and cisplatin 5-fluorouracil. This
TAP. T stands for taxane. I stands for ifosfamide or 5-fluorouracil, and P stands for cisplatin. Okay, so adjuvant chemotherapy is established for any pathologically N2 and N3 disease. The N1 disease, it is only under clinical trial. Okay, adjuvant chemotherapy is only in clinical trial for N1 disease. How will you treat a patient who has got fixed lymph nodes? So we have gone from non-palpable lymph node, palpable lymph node, and pelvic lymph nodes. Now the patient has got a fixed lymph nodes. How will you treat them?
I'll treated him by chemotherapy first. Then if improve, and I'll go by radical lymph node. Then well, if not, I'll treat him palliatively.
Okay, for the sentence, I will treat by chemotherapy first. You can use the statement neoadjuvant chemotherapy. Like any other cancer, if you give chemotherapy first, it is neoadjuvant chemotherapy. In the palpable lymph nodes, we have discussed about adjuvant chemotherapy. Same chemotherapy we are giving as a neoadjuvant chemotherapy. And if they are responders, we will go for radical lymph node dissection. Okay. So how will you follow up this patient? So let us assume you did a partial penectomy. The histology came as common cell cancer grade 3, and you have positive lymph nodes on the right side. Patient's lymph node status is pathologically N2. Okay, how will you follow up this patient?
I'll follow him after for 3 months, for 2 years. then 6 monthly for up to 5 years. Then by physical examination and CT, chest, abdomen, and pelvis, 6 monthly for 2 years, then yearly.
If the patient has got inguinal lymph nodes, they may even require CT or MRI scan 3 monthly for the first 2 years. Okay. Your patient developed a significant lymphedema after radical inguinal dissection and pelvic lymph node dissection. How will you treat lymphedema?
I treated him suppurative underwear first, avoid skin scratch, encourage him movement. Then if not benefit, I'll do sclerotomy or with sclerotoplasty.
Okay, you don't worry much about the scrotum initially. Start with the legs, skin care, exercise, compression device, rule out cellulitis, refer to lymphedema nurse service, which is quite common here. Especially in UK, we have British Lymphatic Society, so the patient can go through that. And if the lymphedema goes to the scrotum, as you said, we can follow up with that. Okay, that's very good. Any other studies you aware of with penile cancer which you can quote? Of course, you can quote EAU guidelines 2022. Any other studies you have in your mind? Just for completion.
No, thank you.
There is a study by name INPACT, INPACT. INPACT stands for International Penile Advanced Cancer Trial, INPACT. Okay, so this INPACT trial is based on rare cancers initiative study. So again, most of the guidelines were based upon the INPACT study. So if you want, you can read INPACT and you can quote that in the exam. That will fetch you a little bit better marks. Good, well done. Penile cancer is quite straightforward. So you can divide the whole thing into the first part of history, focusing on HPV, focusing on exposure, etc. Second part is on penile intraepithelial neoplasia. Third part is on appropriate TNM staging, partial penectomy, radical penectomy, perineal ureterostomy, those things. Then fourth part is the lymph node one. It could be non-palpable lymph node, palpable lymph node with only superficial modified inguinal lymph node dissection, radical lymph node dissection, pelvic lymph node dissection. Sometimes you require adjuvant chemotherapy based upon the PN2 or 3 stage. Adjuvant is only under trial for PN1 stage. But if the patient has got fixed lymph nodes, we need to go for neoadjuvant chemotherapy. If patient responds, we'll go for definitive treatment. If not, patient will be kept on palliative treatment. There is no role for radiotherapy for inguinal lymph nodes because of the presence of the vessels. It can cause significant vascular blown out, etc. So if you understand this in this order, then individually dynamic sentinel lymph node biopsy you can read in detail. You can further put it as we need both nanocolloid, technetium, and also blue dye. Blue dye will increase the sensitivity of the nanocolloid, what time you will do, etc. So slowly you can build on that. So initially create a mental picture of the whole penile cancer, divide it into 5 or 7 stages, and individually for each stage, remember what you will say for adjuvant chemotherapy, what you will say for neoadjuvant chemotherapy, tip regimen, etc. And then finish it off with like lymphedema care and INPACT trial. They will further improve your marks. Very good. Any other questions before we finish the session?
Thank you, Professor.
Good, well done. Okay, guys. Yeah.
Can you hear me?
Yes, Paul. Yeah. Yes.
Yeah. There's the EUA latest guide 2021, which says, PT1A TNM stage, we can give we can do the active surveillance. We should not go for any intervention or lymph node dissection, or that means kind of this sentinel node dissection or modified lymph node dissection? Should we?
Yeah, correct. There is a role for surveillance in patients with PT1A. The reason why we are giving surveillance is the chances of lymph node invasion is so rare. So since it is so rare, we can keep the lymph nodes under surveillance without any steps like, for example, non-palpable lymph node protocol, PT1A. But for PAN, it's a normal protocol of local treatment with lasers or immunocolloid or local application. Yeah, good.
What about supra-regional MDT meeting for these?
Correct.
Because these are rare cancers. Usually, most of people
Correct.
don't do such cancers. So, what to say there? How
No, any penile cancer, right from the starting, you can involve supraregional referral. For example, we have 4 supraregional centers in UK, and lot of centers will say if there is an obvious penile cancer, you don't have to even do a biopsy. You can refer him to supraregional directly, or if they want a biopsy, a good incisional biopsy, including the normal tissue, will prove the histology, and then you can refer.
One last but not least, that usually where we have a habit that we should involve cancer specialty nurse initially.
Yeah, perfect.
However, there is a little bit, kind of how to say, difference of opinion. I mean, I have heard you saying that when we establish the diagnosis of cancer, then we should involve cancer specialty nurse. So, but
Yeah.
usually we forget about that. So it's okay. Is it okay? Just we can say initially when we get any referral from GP, cancer most likely, and we will involve cancer specialty nurse early.
Correct. There is nothing wrong in telling early. So how you can involve them early is in the first clinic itself. If the examination shows obvious penile cancer, if the examination shows obvious testicular cancer, maybe with a vitreous node or supraclavicular node or something like that. If the referral itself says that patient had a CT scan which showed multiple cannonball metastases, if the referral itself says that patient referred with even an ultrasound with a definitive suspicious RCC or a CT scan with an RCC, any of these patients, you can involve the cancer specialist nurse straight away. Cancer specialist nurse doesn't require a definitive histology. All we want is we want to be sure that they are utilized for definitely for cancer. The only things you should not do is you can't involve cancer specialist nurse if it is a visible hematuria. So there is a chances of sensitivity is so low. But if the visible hematuria patient had a plexi, if you picked up a TCC, you can involve the cancer specialist nurse straight away. If they are available, they can see the patient in the hematuria clinic itself. They can give the leaflets, they can give the contact number, etc. But in general, we don't have the facility to have cancer specialist nurse for a hematuria clinic. That's why even if you see the tumor, we will try for a cancer specialist nurse. Otherwise, the cancer specialist nurse can see after TU or BT. So in essence, take-home message is for 2-week wait clinics, have cancer specialist nurse with you. Anybody with a definitive cancer, you can involve cancer specialist nurse even without histology. If it is a suspicious testicular lesion, there is a good possibility it can come as a cyst or epididymal cyst, something like that. Those patients can wait. And once a definitive ultrasound or orchiectomy is done, then we can involve the cancer specialist nurse. Good.
Okay,
Good
I have a
little
bit confusion here in the lymph node involvement. I mean, should we keep this as rule of thumb that one side, if we have detected lymph node, we should do bilateral lymph node dissection, even one lymph node?
For pelvic lymph node, it is only ipsilateral. So if there is a lymph node which is positive on one side, you need to do pelvic lymph node on the same side. For the opposite side, you should do, because if there is a lymph node involvement on one side, it means the patient had lymphovascular involvement and there is a high propensity for the opposite side. So for the opposite side, you will follow the same protocol. If it is non-palpable, use the non-palpable protocol, use an ultrasound and FNAC, and use dynamic sentinel lymph node imaging, everything. If it is palpable, you can
Bilateral, even dynamic lymph node dissection, bilateral, right?
Bilateral we can do, yeah.
Okay,
Because
thank you very much.
changes the staging, and that will also change your pelvic lymph node, whether you are to do bilateral or unilateral. So for dynamic sentinel lymph node biopsy and modified inguinal lymph node biopsy, you can do bilateral, and pelvic lymph node will be restricted based upon what you see in the inguinal lymph node dissection.
Thank you very much. Thank you very much.
Okay, guys, well done. It's not a very big topic. You can sit and read within half a day or even less than that, but very important topic. Next session, we will do testicular cancers. Okay,
That's
I will
fine.
message you the date and time.
Thank you. Thank you very much.
Thank you. Thank you very much.
Good.
Thank
Best
you.
wishes to
Thanks a
everyone.
lot.
Bye.